Hello everyone and welcome to this lecture. Today we will have an audio lecture about residual ridge resorption. Residual bone, that component of maxillary or mandibular bone that remains after the teeth are lost. Residual ridge, a portion of the residual bone and its soft tissue covering that remains after the removal of teeth. Residual ridge resorption, the most prominent continuous surface of the residual ridge, not necessarily coincident with the center of the ridge. Residual ridge resorption is a term used for the diminishing quantity and quality of residual ridge after teeth are extracted. It is a chronic, progressive, and irreversible process, with the rate being fastest in the first 6 months after extraction. The size of the residual ridge is reduced most rapidly in the first 6 months. But the bone resorption activity of the residual ridge continues throughout life at a slower rate, resulting in removal of a large amount of jaw structure. This unique phenomenon has been described as residual ridge reduction. Post-tooth extraction, a cascade of inflammatory reactions is immediately activated, and the extraction socket is temporarily sealed by blood clotting. Epithelial tissues begin its proliferation and migration within the first week, and the disrupted tissue integrity is quickly restored. Historic evidence of active bone formation in the bottom of the socket is seen as early as 2 weeks after the extraction, and the socket is progressively filled with newly formed bone in about 6 months. The most striking feature of the extraction wound healing is that even after the healing of wounds, the residual ridge alveolar bone undergoes a lifelong catabolic remodeling. The rate of residual ridge resorption is different among persons and even at different times and sites in the same person. Structural elements of bone. A basic concept of bone structure and its function elements must be clear because bone resorption can be understood. A basic concept of bone structure and its functional elements must be clear before bone resorption can be understood. The structural elements of bone are osteocytes. These are cells responsible for metabolic activity of bone. Intracellular substance or bone matrix consisting of fibrils or called calcified cementing substance. The calcified cementing substance consists mainly of polymerized glycoprotein. Mineral salts, namely calcium carbonate and phosphates, are bound to these protein substances. Osteoblasts, by their function of forming and calcifying the intracellular substance, are the active bone-forming cells. The osteoblasts surround the bone in a continuous layer. In the course of bone formation, some osteoblasts get engulfed in the intracellular substance and become osteocytes. Osteoclasts are the cellular components of bone that are responsible for bone resorption. Bone resorption always requires the simultaneous elimination of organic and inorganic components of the intracellular substance. Alveolar bone has two structure characteristics. A hard outer layer is superimposed on a spongy, somewhat resilient substructure. A healthy and thoroughly healed alveolar process has a layer of wear-resistant compact bone of varying thicknesses. Beneath the compact bone is the spongy bone. The spaces between the trabecular communicate throughout the spongy bone. Bone is constantly undergoing change in response to replacement and functional demands. There exists a wide variety of shapes and size of residual ridges. Common residual ridge configuration in a system of 6 orders given by outward order. Order 1, pre-extraction. 2, post-extraction. 3, healing, well-rounded. 4, knife edge. 5, low, well-rounded. And 6, depressed. The residual ridge resorption does not stop with residual ridge, but may go well below where apices of teeth were, sometimes leaving only a thin cortical plate on the inferior border of the mandible, or virtually no maxillary alveolar process of the upper jaw. In clinical examination, usually one can visually judge the residual ridge form. However, sometimes a knife edge ridge may be mistaken by redundant or inflamed soft tissue. Pathogenesis of residual ridge resorption. Immediately following the extraction, order 1, any sharp edges remaining are rounded off by external osteoclastic resorption, leaving a highly well-rounded residual ridge, order 3. As resorption continues from the labial and lingual aspects, the crest of the ridge becomes increasingly narrow, ultimately becoming knife-edged, order 4. As the process continues, the knife edge becomes shorter and even eventually disappears, leaving a low, well-rounded or flat ridge, order 5. Eventually, this too resorbs, leaving a depressed ridge, order 6. Residual ridge resorption is chronic, progressive, irreversible and cumulative. According to the American College of Prosthodontics, based on bone height, mandibular only, type 1 residual bone height of 21 mm or greater, measured at the least vertical height of the mandible. Type 2 residual bone height of 16 to 20 mm, measured at least vertical height of the mandible. Type 3 residual alveolar bone height of 11 to 15 mm, measured at the least vertical height of the mandible. Type 4 residual vertical bone height of 10 mm or less, measured at the least vertical height of the mandible. Direction of bone resorption. Maxillary resorbs upward and inward to become progressively smaller because of the direction and inclination of the roots of the teeth and the alveolar process. The opposite is true of the mandible, which inclines outward and becomes progressively wider. This progressive change of the edentulous, mandible, and maxilla makes many patients appear prognathic. Thus, residual ridge resorption is centripetal in maxilla and centrifugal in mandible. Patterns of bone resorption. In the mandible, large proportions of bone loss occurs in the labial side of the anterior residual ridge. Loss of bone occurs also in the equally on the buccal and lingual side of the premolar region. Lingually in the posterior or molar region. In the maxilla, bone loss primarily occurs on the labial or buccal aspects. Therefore, while teeth arrangement, we should try to restore the natural position of the teeth before they were lost. Hence, teeth in the maxillary arch are arranged slightly labial and buccally, while in the mandible, teeth in the anterior region are arranged labially. On the center of the ridge, in the premolar region, and slightly lingually in the molar region. Maxilla vs. mandible. The anterior mandible resorbs 4 times faster than the anterior maxilla. Wolfell has cited the projected maxillary denture area is to be 4.2 square in and 2.3 square in the mandible, which in the ratio of 1.8 to 1. Cancellous bone is ideally designed to absorb and dissipate the forces it is subjected to. Cancellous bone, the maxillary residual ridge is often broader, flatter, and more cancellous than the mandibular ridge. Trabeculae in maxilla are oriented to the direction of compression deformation, allowing for maximum resistance to deformation. The stronger these trabeculae are, the greater is the resistance. Consequences of residual ridge resorption. A. There is apparent loss of sulcus width and depth. B. Muscle attachments are displaced closer to the crest of the residual ridge. Due to loss of vertical dimension of occlusion, lower face height is reduced and mandible is rotated anteriorly. C. Patients may develop habitual prognathic appearance. D. Inter-alveolar ridge relationship is altered. E. Morphological change in residual ridge may appear, such as sharp, spiny, uneven residual ridge. F. Resorption of the mandibular canal wall and exposure of the mandibular nerve. G. Location of the mental foramina close to the top of the mandibular residual ridge. This provides serious problems to the clinician on who to provide adequate support, stability, and retention of the denture. Etiology of residual ridge resorption. In equilibrium, the two antagonistic action of osteoblasts and osteoclasts are imbalanced. In growth, although resorption is constantly taking place in the remodeling of bone as they grow, increased osteoblastic activity more than makes up for the bone destruction, whereas osteoporosis, osteoblasts are hypoactive. And in the resorption related to hyperparathyroidism, increased osteoblastic activity is unable to keep up with the increased osteoclastic activity. Ridge resorption varies directly with some systemic or localized bone resorption factor, and inversely with some bone formation factors. Residual ridge resorption are bone resorption factors, bone formation factors. Systemic factors influence the balance between the normal bone formation and bone resorption. These factors create a natural resistance to unfavorable local factors. They are estrogen, thyroxine, growth hormone, androgens, calcium, phosphorus, vitamin D, protein, and fluoride. Some local biomechanical factors. In relation to periodontal disease, which affects the ridge resorption, number 1, endotoxins from dental plaque on unclear dentures. Number 2, osteoclast activating factor, OAF. Number 3, prosthodontics prostaglandins. And number 4, human gingival bone resorption stimulating factor. Number 5, heparin acts as a cofactor in bone resorption, which is produced from mast cells. Residual ridge resorption is a multifactorial combination of anatomic, metabolic, and mechanical determinants, functional and prosthetic. Number 1, anatomical factors. These factors include amount of bone and quality of bone. Amount of bone. When we clinically examine a complete edentulous foundation, we tend to gauge the residual ridge on the basis of it being high, low, broad, narrow, rounded, spiny, covered by thick, thin mucoperiosteum. The rate of vertical bone loss in broad, high ridge may actually be slower than that of a narrow ridge, because there is more bone to be resorbed per unit of time, and because the rate of resorption also depends on the density of the bone. Quality of bone. The denser the bone, the slower the rate of resorption, because there is more bone to be resorbed per unit of time. 2. Metabolic factors. It includes both nutritional disturbances and hormonal causative factors. Metabolic factors. A. Hormonal factors. Number 1, pituitary gland and hypophysis. Number 2, thyroid glands. Thyroxine also has a direct influence on the kidneys, causing an increased excretion of calcium and phosphorus. This depletion of calcium and phosphorus results in increased bone apposition and increased osteoclastic activity. Number 3, parathyroid glands. Parahormone maintains blood calcium by mobilizing it from the bones through osteoclastic activity. Number 4, islets of Langerhans. The failure of these glands to produce sufficient insulin for proper utilization of glucose causes diabetes mellitus, the syndrome of poor healing, low tissue tolerance, and rapid resorption of bone is associated with the diabetic patients. Number 5, suprarenal glands. The adrenal cortex produces steroid hormones called corticoids. The prolonged use of and administration of such steroids are considered very dangerous to bone tissue. However, one of the beneficial effects of corticoids is to control the defense mechanism of inflammation. Number 6, gonads. In general, the sex hormone, adrenogenes, and estrogens promotes a protein metabolic action on all tissue, including bone. Metabolic factors. B. Dietary factors. Food is classified as protein, carbohydrates, fats, vitamins, and inorganic elements. Inorganic element: calcium salt, calcium carbonate, and calcium phosphate. From the rigid supporting structure of bones. Phosphorus in the form of calcium and magnesium phosphate gives hardness to bone. Edentulous patients should follow a prescribed dietary regimen. This diet should be low in carbohydrates and high in protein intake. The diet should include at least a quart of milk or substitute dietary products, vegetables, fruits, and a multiple vitamin supplement. The normal equilibrium may be upset and pathologic bone loss may occur if either bone resorption is increased or bone formation is decreased, or if both occur. Since bone metabolism is dependent on cell metabolism, anything that influences cell metabolism of osteoblasts and osteoclasts is important. The thyroid hormone affects the rate of metabolism of cells in general and hence the activity of both the osteoblasts and osteoclasts. Parathyroid hormone influences the excretion of phosphorus in the kidney and also directly influences osteoclasts. The degree of absorption of calcium, phosphate, and proteins determines the amount of building blocks available for the growth of and maintenance of bone. Vitamin C aids in bone matrix formation. Vitamin D acts through its influence on the rate of absorption of calcium in the intestines and on the citric acid content of bone. Various members of vitamin B complex are necessary for bone cell metabolism. In general terms, anabolism exceeds catabolism during growth, and conversely, level and convalescence levels of convalescence levels of during most of adult life and is exceeded by catabolism during disease and old age. Bone has its own specific metabolism and undergoes equivalent changes. At no time during life is bone static, but rather it is constantly rebuilding, resorbing, and remodeling, subject to function and metabolic stress. Osteoporosis and residual remodeling. Type 1 osteoporosis is defined as the specific consequence of menopausal estrogen deprivation and characteristically presents the bone mass loss, notably in the trabecular bone. Type 2 osteoporosis reflects a composite of age-related change in the intestine renal hormone function. Both cortical and trabecular bone are affected in type 2 osteoporosis. Number 3, mechanical factors. A, functional factors. Functional factors include the frequency, intensity, duration, and direction of forces applied to bone which are translated into cellular cavity, resulting in either bone formation or bone resorption, depending upon the patient's individual resistance to these forces. Wolff's law postulates that all changes in the function of bone are attended by definite alterations in its internal structure. Forces within the physiologic limits of bone are beneficial in their massaging effect. On the other hand, increased or sustained pressure through its disturbance to the circulatory system produces bone resorption. The amount and frequency of stress and its distribution and direction are important factors in treatment planning. Although the total amount of the necessary masticatory stress cannot be diminished, increasing tissue coverage and decreasing the length and width of the occlusal table may lessen the load per unit area. The frequency of stress application modifies the reaction of alveolar bone to external forces. Constant pressure on bone causes resorption, while intermittent forces favor bone formation. Since recurrent forces over short intervals of time have essentially the same resorbing effect as constant pressure, a rest period between meals is beneficial for this reason. The patient should be warned that gum chewing has a destructive effect on the bone. Bruxism is an expression of nervous tension, which manifests itself as gnashing, grinding, or clenching of the teeth while the patient is asleep or awake. Since most denture patients do grind their teeth in sleep, the dentures should not be worn during this period. Thus, the supporting structures are afforded the rest period essential to the maintenance of the alveolar bone. While the grinding of teeth when the patient is awake may be a habit of tension, it may also be caused due to lack of interocclusal distance. The principal concern should be in the pattern and position of the posterior teeth. There are two mandibular movements associated with the mastication: a closing cutting movement and a lateral or grinding movement. A sharp cusp will penetrate a bolus of food with less force than a flat occlusal form. However, allow physics explains that forces applied to an inclined plane produce a resultant force or vector perpendicular or high angles to the plane. Applying this principle to occlusal form, the resultant force of the steep clinical of high cusps would produce a lateral force, which might cause alveolar resorption. Stress distribution favorable to healthy alveolar bone maintenance is dependent principally upon bilateral balanced occlusion. Balanced occlusion is that arrangement of the teeth which will permit the necessary mandibular movements without tending to dislodge the denture or traumatize the opposing structure. Number 3, mechanical factors. B, prosthetic factors. The prosthetic factors are extremely difficult to evaluate because of tremendous number of variables, including anatomic, metabolic, and functional factors. The traditional design of dentures include many features whose goal is to reduce the amount of force to the ridge and to thereby reduce residual ridge resorption. These prosthetic factors include broad area coverage to reduce the force per unit area, decreased number of dental units, decreased buccolingual width of teeth, and improved tooth form, to decrease the amount of force required to penetrate a bolus of food. Avoidance of inclined planes to minimize dislodgement of denture and shear forces. Centralization of occlusal contacts to increase stability of dentures and to minimize compressive forces. Provision of adequate tongue room to increase stability of denture in speech and mastication. Adequate interocclusal distance during wrist-jaw relation to decrease the frequency and duration of tooth contacts. Treatment and prevention of residual resorption. The best way to manage the problem of residual resorption is by using every means to prevent it. A. Prevention of loss of natural teeth. Clinicians must try to retain residual roots whenever feasible. B. Proper redesign of dentures and maintenance. Optimal tissue health prior to making impression procedures. Minimal pressure impression technique. Selective pressure impression technique places stress on these areas that best resist functional forces. Adequate relief of non-stress bearing areas, example crest of mandibular ridge. Broad area of coverage helps in reducing the force per unit. Snowshoe effect. Increased denture bearing area can greatly reduce the load per unit area on the underlying mucosa and improve denture comfort. Always assuming that the OVD is not excessive. Avoidance of inclined planes to minimize dislodgement of dentures and shear forces. Centralization of occlusal contacts to increase stability and maximize compressive forces. Provision of adequate tongue room to improve stability of the denture in speech and mastication. Adequate interocclusal distance during jaw rest to decrease the frequency and duration of tooth contact. Correcting the occlusal vertical dimension. Clinical studies have shown increased excessive OVD to be a common fault in many dentures. Occlusal table should be narrow. The concept and arrangement of teeth in natural zone helps the tooth to occupy a space determined by the functional balance of the orofacial and tongue musculature. Eliminating disruptive occlusal contacts which lead to denture instability. In general, occlusal tables tend to be too large. This leads to problems of support and stability, which put too much pressure on the atrophic mucosa during function. Overdentures help minimize ridge resorption and contribute to enhance retention stability. Support of prosthesis along with preservation of proprioception. This introduction of dental implants has revolutionized clinical practice. Use of implants for providing implant support or implant-assisted prosthesis also helps avert continuing residual resorption. Reducing the forces required to drive the denture teeth through the bolus of food. This may be achieved by either increasing the denture bearing area or reducing the size and altering the morphology of the occlusal table. C. Nutrition. It has been seen that one of the cofactors in residual resorption is low calcium and vitamin D metabolism. Diet counseling for prosthodontic patients is necessary to correct imbalances in nutrition intake. Denture patients with excessive residual resorption report lower calcium intake and poorer calcium phosphorus ratio, along with less vitamin D. D. Pre-prosthetic surgery. Excessive residual resorption leads to loss of sulcus with width and depth, with displacement of muscle attachment more to the crest of residual ridge. Osseous reconstruction surgeries, removal of high frenal attachment, augmentation procedures, vestibuloplastic or vestibuloplasties, etc., may be required to correct these conditions. E. Immediate dentures. Some authors claim that extraction followed by immediate dentures reduces the ridge resorption. F. Overdentures. Tooth-supported overdentures help to improve stress distribution, thereby maintaining the integrity of residual ridge. A study was conducted with overdentures supported by canines, and it was seen that bone loss was 0.6 millimeter, whereas 5 millimeter in conventional complete denture. G. Osseointegration and implant. Precautions during extraction to reduce residual resorption. When a tooth is removed, the labial plate should be preserved. The labial periosteal covering should remain intact, as its inner layer is responsible for remodeling of bone. If a bone has to be removed, it must be the palatal plate. Thank you for listening to this lecture, and it was an audio lecture, brainless or mindless reading. I didn't quite understand this last chapter, but I'll try to review it and try to understand it.